Hello and welcome to Module 2, Intrinsic Barriers to Wound Healing. In this module, our objectives are to identify the difference between acute and chronic wounds, give an overview of the chronic wound patient, discuss elements of wound pathophysiology, and detail the importance of overcoming barriers to wound healing. Acute wounds heal because cells are viable and respond to growth stimuli. There are sufficient growth factors released into the wound environment. Cells proliferate and can migrate to synthesize components of new tissue. Traumatic wounds and surgical wounds are common types of acute wounds. And acute wounds progress through the 4 phases of wound healing in a timely and uninterrupted fashion. Whereas chronic wounds are wounds that fail to heal and don't proceed through the orderly and timely series of events required to produce a durable, structural, functional, and cosmetically accepted closure. The standard rule of measure is that wounds not achieving 40 to 50% total wound area reduction in 4 weeks will most likely become chronic or non-healing. Chronic wounds need special care with advanced therapies. Common types of chronic wounds are diabetic foot ulcers, venous leg ulcers, and pressure injuries. Let's discuss the chronic wound patient. As the population increases in age, so does the prevalence to develop chronic disease states such as diabetes, vascular impairment, inflammatory conditions, kidney disease, and malignancies. These conditions often result in impaired collagen deposition, lack of angiogenesis, and cellular dysfunction, contributing to delays in wound healing. Many of these same patients are on multiple concurrent medications. Non-steroidal anti-inflammatory drugs, chemotherapy agents, immunosuppressive drugs, and corticosteroids are just a few agents known to disrupt the healing cascade. What are other factors that influence wound chronicity? Growth factors, like cytokines and growth factors that we discussed in Module 1, are soluble signaling proteins that affect the process of normal wound healing. The process of wound repair is controlled by these growth substances. Growth substances impact the wound microenvironment by increasing cellular migration, proliferation, and differentiation. When growth substances levels are low, wound healing will be disrupted. Wound bioburden. Bioburden and bacteria can serve as a physiologic barrier to wound healing. There is a spectrum of wound bacteria that can move from decreased to increased severity. Most chronic wounds are contaminated. There is the presence of bacteria on the surface of the wound. When this bacteria level gets higher, wounds become colonized. This is where there's replication of bacteria on the surface of the wound without invasion into the wound tissue. When levels reach critical colonization, there's replication of bacteria on the wound surface with invasion of the tissue edges. When a wound becomes infected, organisms reach a pathologic threshold, and this will initiate a host response. There is a difference between planktonic and biofilm bacteria. Planktonic bacteria are free-floating, actively replicating bacteria that cause infection. Biofilm bacteria are senescent bacteria. They are found on the surface of the wound. Biofilm bacteria are often tenacious and difficult to treat. They are senescent, but they make connections to each other and do something what's called quorum sensing. They share information and DNA material, And once they mature, they secrete something called an extrapolymeric substance, which is a protective mechanism. The only true way to rid the body of biofilm bacteria is with debridement. Both planktonic and biofilm bacteria impact oxygen consumption in wounded tissue and contribute to wound chronicity. Low tissue oxygen concentration can also affect wound healing. Normally, the partial pressure of oxygen in healthy tissues is about 100 millimeters of mercury. However, upon tissue injury, there is hypoxia where oxygen consumption exceeds the delivery, stimulating the inflammatory process. In instances of chronic wounds, hypoxia becomes prolonged and wound tissue deterioration occurs. Cellular senescence is also a factor for wound chronicity. Comorbidities, medications, advanced age may make certain cells unable to respond to those growth substances we've already discussed, thus causing slow cellular migration and proliferation in wounded tissues. The result is a delay in tissue repair and regeneration. Inflammation is an important step in the healing cascade, as you probably recall. Inflammation increases blood flow, alerts the body to injury, stimulates healing, and attempts to remove harmful stimuli. More specifically, the inflammatory response is histologic response affecting the blood vessels and the surrounding tissue in the injured area. In chronic non-progressive wounds, inflammation is inhibitory to healing. Most chronic wounds are actually stuck in the inflammatory phase. The cytokine environment in a chronic wound is more pro-inflammatory than that of an acute wound, and the ratio of cytokines, especially tissue necrosis factor alpha and interleukin 1b, to their inhibitors is increased. Proteases, or MMPs, in the normal wound healing process are important because they break down damaged extracellular matrix proteins and foreign materials so that new tissue can regenerate. However, when levels of protease activity are too high, such as what we see in chronic wounds, that delicate balance between tissue breakdown and repair is disrupted. Proteases are significantly elevated in chronic wound fluid. Protease levels are tightly controlled in early wound healing. In chronic wounds, protease levels have been shown to elevate as much as 116 times. Lower levels of proteases are noted in wounds that are on a healing trajectory. A disorganized matrix also can impede wound healing. Extracellular matrix, as you recall, is the acellular protein-rich matrix that is essential for the structural support and cellular attachment in wound healing. Abnormal collagen, fibronectin, glycosaminoglycans will all inhibit cellular migration and attachment. Thus, fibroblasts will not be able to produce collagen, and keratinocytes won't crawl across the wound edge to help in epithelialization. They will accumulate at the wound edge. So in summary, failure to regenerate tissue because of comorbidities, concomitant medications, and other intrinsic barriers to wound healing results in ineffective restoration of structure and function of the skin. Abnormalities in skin regeneration leads to the formation of non-healing wounds, including diabetic foot ulcers, venous leg ulcers, and pressure injuries. Early detection of wounds that are not on a healing trajectory will help to improve wound healing outcomes. Promising diagnostic tools are available to detect and track biomarkers, and these have known predictive value, and we'll discuss those in an upcoming module. Here are references, and this completes Module 2. To complete the test, Please click the red test icon at the bottom of your screen with the clipboard and pencil on it to receive your certificate of completion for this module. Thank you.